Health insurance in the United States is incredibly complex, filled with deductibles, copays, coinsurance, narrow networks, and more. Why is our system such a maze? Is it the unintended product of decades of patchwork policies, or is the complexity intentional? Welcome to CareTalk, America's home for incisive debate about healthcare business and policy. I'm David Williams, president of Health Business Group.
And I'm John Driscoll, the chairman of the UConn Health System. David, complexity, that's just such an Ivy League word for you don't understand. I mean, what are we talking about here?
Oh, well, it means complicated, John. It is complicated, I guess. That's the thing. So, I mean, when you say, wow, this is complicated, what are we talking about? Well, the thing is, part of it is just calling it healthcare system, right? It's not one system. You'd say, like in the UK, it'd say the NHS, there's National Health System. There is a system. Here, there's not one single system. There's a bunch of parallel ones. There's the employer-sponsored, there's the Affordable Care Act, there's Medicare, Medicaid, the VA, all sorts of stuff. I mean, I think that's where it starts. And each one of those has its own rules and structures and payment models. People can be in more than one. If you're a provider, you have to deal with all of them. And then the consumer is faced with all sorts of stuff in terms of cost sharing with all sorts of different names. And that's just the start of it.
David, every healthcare system is complex, as you like to say it. Like, what makes that complex? What makes the U.S. healthcare system's complexity a problem for anyone other than you?
Oh, maybe I'm the only one. All right. So can I point out my wife? Sure. So before we were married, we were in business school, and she needed surgery on her hand. And then she's from Canada, I should indicate. So anyway, she ended up with a bill. Somebody sent her a bill and she was in tears. They sent her a bill for like $30,000. Why? Because she was prescribed OT, occupational therapy, but somehow she was given PT, physical therapy, which wasn't covered. And she's like, oh my God, it's like her whole, it was like, you shouldn't have that money. What was she going to do? And I just told her, just ignore it and don't worry about it. So, I mean, that's an example, John, and that's just one little example, but that happens for people every day, all the time, including people in healthcare who think they should know.
But isn't healthcare always complicated? I mean, what makes the U.S. healthcare system any more complicated than any other system in the world?
Well, a lot of it is this third-party payment, John, and the need to sort of pin the payment somewhere.
Okay, smarty pants healthcare guy. What is third-party payment? Why don't we speak in language that humans can understand?
Well, John, the thing is, AI is taking over. I'm not so sure it's important that language that humans can understand as long as they've got an AI to help them with it. But third-party means somebody else. Sort of like if I were to pay, like if I were to sell you a hamburger, John, which I'd be happy to do if I owned a McDonald's. You pay for it. Now, if it turns out that, I give you the bill, and let's say it's for a $5 hamburger, I give you a bill for, let's say, $50. And then if you don't have insurance, then you say, okay, then you pay it, or you don't pay it and you run out. But otherwise say, well, I'm insured. So in a few weeks or months, I'm going to get something, and then the insurance is going to pay me $3.26 for the hamburger. And then they're going to charge you $5 for it. It's just very complicated. It's somebody else other than the customer or the patient paying.
But David, as we think about U.S. healthcare systems versus other systems around the world, almost all of them actually have a lot more of what you call third-party payment, what I would just think of as insurance. So I'm not paying the bill if I get sick in the downtown London or the suburbs of Tokyo. The government, is some form of government insurance, or if I'm in the case of Germany or Switzerland, it's sort of backstopped by benefit design and national coverage, but still private pay.
Yeah.
But I'm not paying the whole bill. Some form of government or private insurer is. What's so different about the U.S.?
Yeah. Well, one thing that happens, so John, now I think you're changing the point because you don't want to talk about the U.S. You're trying to get me to talk about East Germany or whatever you're coming up with. I mean, one thing that makes the U.S. different is that how this sort of insurance for healthcare started. And a lot of it had to do with the wage controls during World War II, where I couldn't pay somebody. I needed laborers. I couldn't pay somebody more. That wasn't allowed. So I had to entice them in some other manner. And providing a nice little benefit, sort of like a company car was one thing to be done. And health insurance caught on then. And then things were added to it over time, in particular Medicaid and Medicare in the 60s. And then you had things that came on that. And we've never kind of replaced one thing with another. It's always been additive. So I think that's one of the things that's a lot more complicated than in some of these social welfare states, let's say in Europe, that emerged after World War II.
I'm trying to lead the witness back to your complexity point. The way to think about, human history is that, up until probably the late 19th century, there was modest increases in how long you lived and how long you worked. In the early 20th century, the combination of clean water and vaccines, yes, those things that are now being brought into question by people who just ask questions, had a massive effect on the advantage of public health and public sanitation and improving and extending lifestyle, and so extending people's lives. And so the late 19th and early 20th century was also a period when many of initially in Europe and then spreading to the U.S., more and more folks were insured. The quirky thing about the U.S. is when companies, to your point, couldn't pay any more money, they decided to compete for employees based on creating the health insurance that had already been, innovated about, engineered in the UK. What that has left us with, I think, is a system of incomplete private insurance and incomplete public insurance, the Medicare and Medicaid, Medicare for the elderly, Medicaid for the poor. And those three systems, before you get into all your little specific examples, David, I think it's sort of a table with three legs when it needs a fourth, and fourth is uncovered effectively. So it creates kind of a wobbly system that is hard then for everyone to navigate because it's incomplete. And you want to just kind of explain what how that incompleteness plays out in terms of for patients and for docs?
Sure. But as long as you're doing the world historical tour, let me do one other thing, which is to say, It's sort of like, it's like when they find a Japanese soldier on some Pacific island, 22 years later, say, hey, the war is over. I mean, the war ended in 1945. You'd think we could have gotten past, some of these things. I think there's actually a cultural difference in the United States that actually has this impact, which is that in some other countries, they actually start with the presumption of universal coverage. So you don't see a patient and you say, hey, that person, they're not covered. People are covered. That's the idea. Here, there's the idea, maybe it's okay if people aren't covered. And increasingly, that's the case when we talk about someone based on, let's say, their immigration status or some other factor that makes them ineligible. So there's even a question about whether an individual in the country, even a citizen, is covered or not. And I think that has an impact when somebody's accessing the system, because if there's a provider that has to pay their bills, they're not even sure if they can get paid for a fair fraction of the patients. And I actually think that may be something different here than elsewhere.
There's no question. But what's interesting is where Obamacare was super successful is extending coverage to the highest levels. I think it's closer to 90% at its peak. Maybe it's just high 80s. And from numbers that were substantially less, and every incremental a percentage point of person or person covered means those doctors don't have to worry about getting their bills paid, to your point, which creates kind of some stability in the system and allows for folks to stay involved and get, since we're a nation whose biggest challenge for public health is chronic illness, it allows you to get someone into chronic care management and potentially really reduce the amount of pain and suffering, and also reduce the amount of costs for that patient or that covered person over time. And you raise a really interesting point. So how's all these cuts in coverage for Medicaid and immigrants and just increasing cost, reducing the ability for employers to pay for full coverage. How do you think that's going to affect the healthcare system, Dave, given that that's what we're dealing with right now?
Yeah, I mean, not in a great way, right? So if you look at what Obamacare did, is one of the goals was to get more people into coverage, and it's quite successful at that. And I think it actually did go above 90% coverage. Now, the way it was done, the Democrats were they thought it was important that it be bipartisan, and so they included a lot of the Republican ideas, such as they were in Obamacare. One of them had to do with individual responsibility, which meant that people had to have insurance. They had to pay for it, and and to be in the system. That's since basically struck down. But what instead of going for, let's say, single payer, like in some of these other countries, they said, let's actually work with what we've got and extend it. So one of the main ways that coverage was extended was by expanding Medicaid, and also by making private insurance more affordable through these exchanges. And so as those pieces are then pulled back, stripped away, or in the case of the Medicaid expansion, never fully implemented due to resistance by certain Republican leaning states, you still have this patchwork where some people are covered and some people are not. When you pull that back further, but leave all the other mechanisms in place, it means the providers are going to need to get paid somehow. And so that's going to make things more complicated. And John, it's going to make it more expensive for those who actually have coverage. And ironically, John, there is this talk about people being freeloaders on the system, usually talking about poor people, right? But why are we having the pullbacks? It's not because of some great insight. It's in order to fund tax cuts for the upper millionaire and billionaire class. It's just a fact.
And so, Dave, I go back to, if you could use language that everyone could actually understand this time, why is healthcare in the U.S. so expensive?
John, you make me tie both hands behind my back because it's hard to explain that, and I don't know if I could use it with the the words that are taught in our failing education system. So why is it so expensive? Well, I mean, one reason is that actually prices are high, and so the price for a given, I'll try to use a simple word. So the price for a doctor visit is higher here than elsewhere. And it's partly because the physicians are paid more. So say if you see a specialist, it may be that it's more expensive because their pay is higher. Now, another reason is because of the cost of complexity. So if you have to figure out whether somebody is actually eligible for payment at that moment, if you're going to get paid, and who to bill, and then what you're going to do when they say they don't want to pay it, and what you have to do before to ask about being paid, that actually drives up the cost as well. So there's higher prices, higher unit prices, and then there's more overhead associated with those. Those are two of the big reasons.
I'd start with drug pricing, because we don't have a true agreement, regardless of, I don't know what or RX is. We do not have an agreement on how to reduce sustainably drug costs that are materially higher here than everywhere else in the industrialized world. We do not have agreement on how to keep everybody covered. And without people staying covered, those people are still going to get sick, but they'll be much more expensive when they get sick. And we've got a cost problem. And we've also restricted the amount of doctors and nurses that can come into the country and practice. So we made it even harder to get care. Yeah. So I think that, to me, is the four horsemen of the affordability matrix. I mean, the unaffordability matrix. I guess, Dave, if you were to design a system, right? Pardon me. I keep forgetting. I think, aren't you responsible for the Republican alternative to Obamacare? How's that Republican alternative to Obamacare kind of working for you?
It's like, John, it's always like, that song, tomorrow, it's always a day away. So I think in the next 2 weeks, we're expected to see a plan. John, the reason you won't see a plan is because certain concepts were actually incorporated into the Affordable Care Act, and then they became instantly poisoned because people were so excited to go after then President Obama. So the things I hear are not serious in terms of reducing cost, and I think this is really going to be an issue in the upcoming elections, assuming that we're expecting to continue forward with the elections, because this theme of affordability is so important. And when you talk about affordability, healthcare is probably the number one issue, really, because it's very big and it's grown fast and it's hard to control. So housing, which has been a focus, yeah, that's a problem too. But there's choices you can make, whereas in healthcare, not that much you can do about it. And I don't think Republicans have any idea about really what to do about costs. If we get to the pricing issue of drugs that you raised, there is a tool that's being used, John. The one tool that's being used is from the Inflation Reduction Act, which is being completely pilloried by Republicans, except when there's a negotiation for a drug. That's actually from the IRA, and that is what is using to actually negotiate prices
Biden's
with the
Inflation
Biden's.
Reduction
That's
Act.
Bidenomics, John.
I guess, Dave, you gotta, anyone has to have some sympathy for the Republicans to try to tackle the total cost trends in healthcare. And I think that some of the solutions that they've been talking about, giving people more money for their HRAs or HSAs, I don't know what, write the check to the person, not the insurance company, is going to do, because the insurance company is the one that's got to pay the bills. And some of the stuff's a little silly, but I think they're trying to crack a real problem. But the foundational solution, which was the foundation of Obamacare, was everybody's got to get covered. They don't be all covered at the same level. And perhaps you could say that the Obamacare may have had some richer, you can argue about how rich the plan should be. And you could argue about the timetable, but without everyone being covered, to your point, when a substantial minority and an increasing minority, when benefits are being cut for the poor and the working middle class, and that value is being shifted to millionaires and billionaires who don't need it, what that leads to is a higher cost trend, more people getting sick. And so I think the problem with a solution is it starts with a commitment to national coverage, which seems to trigger a real reaction on the Republican side. Do you think they'll come up with will the Republicans come up with a healthcare plan this year, David?
No. And I'm going to take issue with the first thing you said, is that we have to have sympathy for the Republicans. No, I think that's bullshit. I think that there's a lack of patriotism, which is driving this. If you want to go after healthcare cost and quality, it needs to be done it's a national priority. It's like defense. It should actually be done in a bipartisan way, and it should sort of hit the reset. And let's look at the assumptions and not be blind to crazy ideas, like the idea that you're going to give somebody a couple $1,000s in their HSA instead of as a subsidy to buy insurance, and they're going to go negotiate. Who are they going to negotiate with? You can't even get anybody to do it. No, I think we should look at the plan. So that maybe what should happen instead is the Democrats should go back to what their plan actually was going to be if they're not going to get any Republican support for it, including things like a public option, which is health insurance that is moving, basically saying, hey, we'll compete with the private market.
Before you get there, I mean, just the amount of, I think to cover a typical family of four is north of $25,000 a year on average, and the out-of-pocket costs are between $6,000 and $8,000 for covered employees. And so these dollars are tips, not the substance of what would actually provide meaningful coverage. And again, everything has to start, however designed, with meaningful coverage for all. Before you even get into how you fund it and what you call it, David, I think that has to be that was the clear assumption of Romney Care, the Republican-led reforms in Massachusetts.
But very bipartisan. It happened under him, John, but it was bipartisan. And it wasn't that Romney pushed it. That was a nice name for it. He signed it. He wasn't the champion of it. That was groups coming together, and not just left and right either. It was the industry, the healthcare industry. It was businesses. It was community folks. And the idea was costs have been rising. Let's get everybody into coverage, and then we're going to deal with the cost, because we're talking a long time. We need to have affordability first before we can actually get everyone in coverage. And they said, no, let's actually get people in coverage. Now in Massachusetts, we have a huge cost crisis too. So that has to be dealt with.
Before you get there, David, in the case of Romney Care and Obamacare, as more people got covered, cost trends abated. I mean, the math's pretty clear on that. So while a lot of the healthcare drivers, they didn't all go negative, but those cost drivers actually abated a bit. And that matters. When you introduce managed care organizations, HMOs at scale in the 80s and 90s, it really broke the back of healthcare inflation that really plagued us as a country in the 80s into up till when Clinton was elected in 92. The next big change in healthcare cost trends happened after we started covering more people, which was exactly the assumption, which is why I agree with you. I don't think we're going to get a plan in a meaningful way to reform a program that I think there seems to be some tribal distaste for at the leadership level. But honestly, there's a lot of happy Obamacare covered members in red states who are going to get a rude surprise when they see their premiums go up, or they won't be able to get coverage at all.
That's right. So, John, one thing maybe the Republicans could do is just actually re-embrace some of the things that they liked in the first place. So one of them would actually be don't vilify insurance companies. I mean, if you say that's going to be a private sector and someone's going to manage the cost, it's the insurance companies. So maybe allow them to, to do what they need to do. And also rethink this idea. If you have an insurance pool, rather than saying, let's rip people out of it and say they don't need to be in coverage, or they can be in some sort of a mini med plan or something that's not really covering. So actually, get everybody to be in coverage, make it affordable, actually reduce some of the regulations that do and mandates that actually make it more expensive, and allow the market to work in places like negotiating for drug prices for which they've currently been hands off.
So you're basically saying that the best fix for Obamacare is reform, not reject.
Yeah, I mean, I think when as soon as the law was enacted, there was an attempt to undermine it, and also you normally have such a big complex piece of legislation, and there's issues with it that need to be straightened out over time. And in an attempt to undermine it, which have been successful, Republicans refused to make those adjustments. So one example is the ratio of premiums for the oldest versus the youngest in the Obamacare exchanges, and the ratio isn't high enough. So you don't actually have the right kind of a balance so that you can make money with the full spectrum of ages in there. So there's a bunch of technical things.
You make a really important point, though, David, that whenever any large bill has been passed, historically, once the bill has been passed, Medicare, Medicaid, civil rights, even the defense authorization bill, the annual bills, there are things that emerge that one finds that there is largely bipartisan support to refine the fixes and tweaks to make it work. All of them were rejected by the Republicans during the early days of Obamacare, which is one of the reasons why it wasn't reformed, even to solve some of the problems that they identified very early. And I think, but that tribal distaste for embracing anything, even if the Republican constituents liked it, is I think why we're going to be continuing to circle around this, Republican plan. I think what I think is sort of sad, though, is there are millions of people who are going to be caught, have real personal tragedy and stress because they're going to lose coverage because of tax policies that favor millionaires and billionaires, folks like you, David, and
Amen.
who, but at the expense of people maintaining coverage, because a lot of those folks who are being thrown off of Medicaid, who can't afford Obamacare premiums, are hardworking, working class Americans who are in many cases working 2 jobs, and they can't get coverage. They can get any coverage from either.
Right. No, it's terrible. One of my pet theories, John, is that because it's been nicknamed Obamacare, I mean, that's not the name of the law. That is actually why the current president and maybe some of the Republican colleagues are so against it, because it's associated, with a specific individual whom they don't like. It'd be better if they going back to calling it, PPACA, Patient Protection Affordable Care Act, or
just
the
maybe
ACA.
retitle it "Make Obamacare Great Again."
Just call it care, and have the same thing and probably become very popular at that point. It could be like, what they do with
kind of divide the country, though.
Well, it's sort of like, do they still have this, MLK/Lee Day? You could do it that way.
So let's move on to, maybe for one final challenge, Dave.
Yeah.
Dr. Complexity, lots of complicated answers, just going to kind of take you into the weeds. Okay, what's the one thing you would recommend, Republican or Democrat, that would help us actually cover more people and deliver better care and lower the cost trend? One thing. That's all you get.
Okay, fine. So one thing that it's going to focus on the simplicity which is mandate that that every payer has to pay the same price for a service, so that a hospital has one price that they charge, and that's it, and everybody pays it, and you know what the price is.
So it's the Maryland model, the all-payer model.
But that's right, but at a federal level. So keep all the payers. You're not going to put them all out of business. But if I'm a provider offering a service, I'm indifferent to whom I'm charging for it, because it's going to be the same price. Just like at a gas station, they have one price. They don't charge everybody a different amount, and you see the amount, and that's what you pay it. So if you gave me one thing, that's what I'm going to take.
Yeah, I'd probably take Medicaid managed care for anyone who doesn't qualify for commercial insurance. It's the idea that I stole from you, but I'm going to take credit for it that works. Because
Driscoll care.
It would improve the risk pools for Medicaid. You could stabilize. One of the problems of Medicaid is the uncertainty of whether you're going to stay and keep coverage. And the current big ugly bill actually is going to make that coverage harder. But if you could maintain it, and it's relatively low cost, it would be an investment, but it's really an investment in the health of working Americans. I mean, 50% of all kids, 40% of all kids today are born on Medicaid. There's a lot of good things about Medicaid. It would also, I think, require us to invest more resources. But I like your idea too. So with that, I think we wrap today.
That's it for yet another episode of CareTalk. We've been discussing what makes health insurance, and apparently my choice of words, so complicated. I'm David Williams, president of Health Business Group.
And I'm John Driscoll, the chair of the UConn Health System. If you liked what you heard or you didn't, we'd love you to subscribe on your favorite service.